Hi, my name is Kristen Campbell, and my friends all know me as KC, so I hope you will as well. I am a pediatric nurse practitioner at Yale New Haven in the United States, and that is a role that may not be familiar to some of you here in Czech. A nurse practitioner is the training of a nurse. I worked as a bedside nurse for many years in the pediatric intensive care unit and hematology oncology units for children. But I went on to have a master's degree in nursing as well, which means that I am now licensed to prescribe medications and also diagnose. So I can diagnose and treat patients on my own in the state of Connecticut. So it's a role that may not be as familiar to you, but is one that is really well utilized on palliative care teams in the United States right now. I'm here today to talk to you about communication in palliative care. If you've heard anything about palliative care, you've probably heard that communication is the meat and the potatoes. And when I'm thinking about communication, I'm thinking about it as a two-way street between providers or clinicians and family members. We are thinking about the need to gain respect and gain trust, but also to be listening so that we can hear the things that are important to the patients and the families that we're caring about. Listening is probably 90% of my job in palliative care. As a better listener, I can make better treatment plans for my patients and their families. There are different things that we need to communicate about, and one of those is breaking bad news or communicating a difficult prognosis. Communicating a prognosis that we know may be upsetting to families is hard, it's necessary, and we always want clinicians to know that it doesn't take away hope that families have. So reasons that it's hard for clinicians, a lot of times we're worried that we're going to upset the families. A lot of times we have fear that we're going to have them think that the end is near, that their child is dying and that they have no hope anymore. And we worry that we're not going to do a good job at saying the words the right way, or that we might become emotional. But what we know from family members is that they want to hear the truth. They want to hear real information from clinicians that they trust. And if we can have those honest conversations, if we can have that trust, if we can have the openness about realistic information and the prognosis that their child has, then we know that they will be in a better position to make better decisions for their children. And what studies have shown us is that if we are honest about prognostic information, then families are more likely to be able to focus on quality of life as they near the end of their child's life, and they are less likely to accept invasive or intensive interventions. We also know that studies have shown that it doesn't steal hope. It may be upsetting for families to hear bad news from us, but that doesn't mean that they don't want it from providers that care about them. They want to know that we are going to be honest with them every step of the way and that we'll be there with them for every step of their journey. One of the models that we use frequently in the United States, and it sounds like the Czech Republic is using it a lot here as well, is the SPIKES method. So SPIKES is S-P-I-K-E-S, and it's an acronym for steps for bearing difficult news or communicating a prognosis. So the first S is setting the stage. We want to make sure that we are setting up a conversation for success, that we are having a private, quiet environment, that we are making sure our families are ready to have a conversation, that we have access to language interpreters so that we can communicate in the language that they understand, that we have the right people there. Making sure that for the family or for the patient, they have the people that are important to them in hearing medical information and making decisions, that they're at the table, and also that the clinicians that are important are at the table. So we think about having a provider that knows them really well, whether that's a physician or a nurse practitioner. We think about having psychosocial support. So if it's a family whose religion or spirituality is important, we might have a chaplain. We should have a social worker, someone that's ready to make the next steps and respond to their emotions all together as a team. P is about their perspective. So we want to ask families, what is your understanding of where things are right now? Or what is your understanding of the illness and what's been happening so far, this hospitalization? We need to hear what our families and patients already know so that we know how to guide the conversation. And one of the best methods for getting that perspective is ask, tell, ask. So we ask for their understanding, we let them tell us what they know, and then we ask again to check that we did a good enough job and that their understanding is correct. Then we want to have an invitation. So we want to make sure that we have permission to have a difficult conversation. We say something like, we have the results of your scan back. Is this an okay time to talk about that? And if our families say yes, perfect. We move forward with the conversation and the next steps. If they need time, if they're anxious, if they need someone else to be present for them to hear that information, then we make a plan as soon as possible for the next time that they're ready. K is knowledge. So we want to share and tell what we know, and we want to do that as simply and honestly as possible. We want to say something like, unfortunately, the results of your scan show that your tumor did not respond to chemotherapy or radiation. The tumor is growing, and we are worried that your tumor will cause you to die. And that's really difficult. We know that headliner, that one line that we say, is going to change a person's world, right? It may be devastating. It may be what they were expecting. It's maybe not what they were hoping. It's most likely not what they were hoping. And so we need to be ready for the next step, which is E, emotions. We expect emotions after we share difficult news with a patient or a family, and that's a part of our job. When families are upset and sharing their emotions, we know that it's going to bring feelings up in us, and that's okay. As long as your emotions are kept down to a point that a family does not have to comfort or console you. We want to make sure that we're able to let a family feel their emotions. If we set the stage correctly with our first S, we may have tissues available, but we don't need to rush to hand them to a patient. We can let the tears fall and have them be close by if needed. So when we think about responding to emotions, we think about nonverbal responses and verbal responses. Non-verbally, we want to lean in, we want to soften our glance, maintain eye contact, and just hold silence. Sometimes the greatest word in palliative care is no word at all. A pause or silence to just allow the heaviness of an emotion to exist can be the most beautiful gift that you can give a family, just being present. And when we feel that it's time to respond verbally, sometimes we use a mnemonic called NURSE. NURSE stands for name, understand, respect, and support. And the NURSE mnemonic is named after our nursing colleagues. I'm proud to be a nurse first. And that is because nurses are known as incredibly compassionate and caring providers in the United States, and I'm sure they are here as well. So when we nurse an emotion, we name it. I can hear how angry you are, or I can see that this is devastating news. And then we understand it. So we express that we understand not that what they're going through, but we understand the depth of the feeling itself. Saying something like, I could see how this would be incredibly hard to hear after all that you've been through. And then we respect the emotion. So that's basically saying, like, we acknowledge the strife that you've been, or even praising families. You have been such an incredible parent, and I love the way that you have worked together every step of this journey. This is really difficult news, and I see that it's weighing on you. And then S is the support statement, and this is my favorite one. And that is basically to say that we are in this together, that we're not going anywhere. And that could be anything like, we're gonna be here with you every step of the way. Once we've nursed the emotion, once we've given that emotion a little bit of time to settle, we jump back into spikes and we hit that last S. And that S is strategy and summarize. We want to make sure that we are summarizing what happened in the meeting, making sure that what information was shared is clear and that they know the next steps. That's the strategy. We want to make sure that the family leaves while having a lot of upset. I'm certain that they know what is happening next. And that may be a next treatment. That may be 24 hours for them to process or share with their other loved ones. But it should always involve a plan to follow up with us, for us to check back in and see how they're doing after hearing this difficult news. When I think about the honor that it is to sit with families in their most difficult moments and the difficulty that it is to share some of this news, I always want to keep in mind these mnemonics and how they can serve as a guide to really help these conversations run more smoothly and for you to make sure that you're doing your absolute best job as a provider in palliative care. So thank you so much for listening, and it has been such an honor to enjoy and explore your beautiful city. I hope to return to the Czech Republic soon. Thank you.